Hello everyone, this is podcast 12 of Let's Revise MBBS, and today's topic is abortion and medical termination of pregnancy. Right, so what is abortion? When do we say that the fetus is aborted, or when the abortion has happened? So any pregnancy loss which is before the period of viability, or to be specific we can say any pregnancy loss which occurs before 20 weeks is known as abortion. Okay, this definition is followed in India, but according to WHO, it is pregnancy loss when the weight of the fetus is less than 500 grams. Okay, right. So let's classify abortion. Whenever we say abortion, for layman or general public, it is most of the time induced abortion. But abortion is classified into two types, either spontaneous or induced. Okay, induced is MTP, which we will talk about later, but spontaneous again has two types, either isolated or sporadic and recurrent. Okay, isolated and recurrent. Okay, this is one classification. The other type of classification is we have six types. Okay, the first one is threatened abortion, like it's threatened, abortion may occur. Second one is inevitable abortion. Third one is incomplete abortion. Fourth one is complete abortion. Fifth is missed abortion. And the last variety is septic abortion. So let's talk about each one of these. So threatened abortion. So here the process of abortion has begun, but it is still reversible. It is not inevitable. Abortion can be prevented at this stage. Okay, and what will the patient present with? She will mostly have spotting and some slight amount of bleeding, but the height of the uterus will correspond to the period of gestation. Okay, because the fetus is still there inside and internal os will be closed. That's why the pregnancy is still viable. If the internal os would have been open, it wouldn't have been threatened. Okay, so this is about threatened abortion. Next is inevitable abortion. It is similar to threatened abortion, just that we cannot reverse the process of abortion. It has started and it will get completed. Okay, here also the symptoms will be bleeding of the patient, but when we see internal os, it will be open. Okay, right. Next is incomplete abortion. Incomplete abortion is some products of conception have started coming out and the process is still not yet complete. It will definitely get completed, but it's not yet complete. So patient will complain of some fleshy material coming out and also some bleeding. Okay, and the internal os will be open because the process is still going on. The next one is complete abortion. Here the entire process is completed and she'll complain of product of conceptions coming out along with bleeding, but now there are no symptoms. Okay, now if we see the internal os, it will be closed and the height of uterus will be less than the period of gestation in both these cases, in incomplete abortion also and in complete abortion also. Okay, next one is missed abortion. Missed abortion is that the fetus is there inside the uterus, but it is dead, and because it is dead, the secretions of the vagina are brownish in color. Okay, but the internal os is closed. She will not complain of any fleshy material or any products of conception coming out because internal os is still closed and fetus is still inside, but it is dead. Okay, and the last variety is septic abortion. Any of these abortions associated with any sepsis or any infection is known as septic abortion. It mostly occurs when the abortion has been done in an illegal way or not by a doctor. So that's a separate variety, which is septic abortion. So these were types and classification of abortion. Coming on to specifically the sporadic or isolated type of abortion. So most common cause of isolated abortion are chromosomal anomalies. And what is change in number of chromosomes called? Like either diploid, either trisomy, either monosomy, anything. In total, we call this as aneuploidy. Euploidy is correct number of chromosomes. Aneuploidy is different number. Okay, so if in the option we have aneuploidy as the one of the options, we should mark aneuploidy for most common cause of isolated abortions. Okay, if aneuploidy is not there in the option, so aneuploidy can have either trisomies, monosomies, like that. So if aneuploidy is not there, we will go for trisomy. Okay, trisomy is a whole group. Any trisomy is possible. Trisomy 16, trisomy 18, trisomy 21, any trisomy. But overall trisomy is common, most common you can say. But if you are asked individual about trisomy is like an entire group of trisomies. But monosomy X, monosomy of chromosome X, it is a single most common single chromosomal anomaly. Like it is specific to chromosome X. Okay, so I'll revise. If the option has aneuploidy, go for aneuploidy. If the option doesn't have aneuploidy, go for trisomy. If trisomy is also not there in option, then go for monosomy X. Okay, if you have trisomy 16 as well as monosomy X, you will still go for monosomy X, because trisomy 16 alone is not more common than monosomy X. The whole group of trisomy is common than monosomy X. Okay, so final order is aneuploidy, not in the option trisomy, not in the option monosomy X, not in the option, then go for trisomy 16. Okay, infection is another cause of single abortion or isolated abortion. Okay, and some important point about infection is that none of the infection can cause recurrent abortion. If the patient is having recurrent abortion, then she is not having any infection. There is one exception to this, it is syphilis. Okay, and there is a law which is Kassowitz law, Kassowitz, Kassowitz law. It says that as the pregnancy loss increases, like if there are 3 or 4 pregnancy losses, every time the time or the week at which the pregnancy is lost goes on increasing. So if initially it occurred at 7 weeks, then it will occur at 9 weeks, then at 12 weeks, then at 14 weeks, like that. So, but the syphilis is exception. Rest all other infection cause only isolated abortion. None of the infection causes recurrent abortion. Okay, right. Now moving on to recurrent abortion. What is the definition of recurrent abortion? It is either 2 or more documented abortions or 3 or more abortions. Documented is if the patient is having document like USG, proper document that USG suggesting 2 abortions, or she has a prescription by the doctor that she has undergone 2 abortions. If it's documented, then more than 2. If it's not documented, then more than 3 or more than 3. Okay, most common cause for recurrent abortion is, we don't know, idiopathic. Okay, but second most common is uterine problems. So in uterine problems there can be either congenital anomalies of uterus like septate uterus, which is common, or it can be problem in the cervix, okay, which is cervical incompetence. Other reasons are autoimmune. In autoimmune we have Apla syndrome, SLE, then hypothyroidism, diabetes. All these are other causes. So 2 main causes which we will talk about here is cervical incompetence and in short about Apla syndrome. Okay, so Apla syndrome is anti-phospholipid antibody syndrome. So in these conditions there are antibodies against the phospholipid, and there is increased chances of thrombosis, and if you do PT and APTT, PT is mostly normal, APTT is prolonged. Okay, so there are 2 clinical criteria and laboratory criteria. If any one of the clinical criteria and one of the laboratory criteria is present, we diagnose it as Apla syndrome. Okay, you read about laboratory and clinical criteria. Right, now how do we treat it? if Apla syndrome is associated with recurrent pregnancy losses, then we give the patient aspirin along with heparin. Okay, but if she is having Apla with no history of recurrent pregnancy loss, then we only give her aspirin. Okay, so that was about Apla syndrome. Coming on to cervical incompetence. So what is the meaning of cervical incompetence? The cervix is like a door or is like a passage for the fetus, and it should remain closed during the entire time of pregnancy. Okay, if it opens, then the abortion will occur. The cervix needs to be competent to maintain the fetus inside. Okay, if it is not competent, abortion will occur. Okay, so abortion due to cervical incompetence mostly occurs in second trimester, and the patient will complain of recurrent mid-trimester loss, and there will be painless. This bleeding and abortion will be painless. Okay, so how do you diagnose this cervical incompetence? First of all, the patient will come with this history of recurrent second trimester pregnancy losses. Then clinically, if you want to check, then it depends. If the patient is not pregnant right now, you can use Hagar's dilator, and there are various sizes available. So if number 8 Hagar's dilator is easily passing through the cervix or is passing without difficulty, then it is a case of cervical incompetence. Or if it's during pregnancy, you check the length. If the length is less than 2.5 centimeters, length of the cervix is less than 2.5 centimeters, then you can label it as cervical incompetence. Also, there is something called as funneling. It's better if you see the diagram of funneling. So if the funneling is of more than 1 centimeter, you can also label it as cervical incompetence. Okay, and in contrast to what we saw in syphilis, here as the number of pregnancy losses increases, the age of abortion decreases. So if the first abortion was at 18 weeks, the next will be at 16, further will be at 14, like that. Okay, but all will be second trimester abortions. So how do you treat it? We have cerclage procedures. So mainly two, McDonald's and Shirodkar's. The preferred one is McDonald's. Okay, in McDonald's we use purse string sutures at the level of internal os. What is the timing of doing cerclage? So it is 14 weeks, because second trimester starts from 14 weeks and the abortion mostly occurs at 14 weeks. So we do cerclage operation at 14 weeks, but any time up to 24 weeks is okay. Preferred is 14 weeks, and we remove this at 37 weeks or at the onset of labor. Okay, so this was about abortion. Coming on to MTP, which is medical termination of pregnancy. So here there are some new laws which have come up now in 2020. They haven't been passed yet, but they'll soon be passed. So I'll compare old as well as new. Okay, so initially MTP was allowed up to 20 weeks. Now it is allowed up to 24 weeks. Okay, initially in the old criteria, MTP before 12 weeks required only one doctor, and 12 to 20 weeks required 2 doctors. Now till 20 weeks we require only one doctor. From 20 to 24 weeks, advice from 2 doctors are required. Okay, and initially, even though there was any severe congenital anomaly, MTP beyond 20 weeks was not allowed. But now, if the fetus has severe congenital anomaly, abortion even after 24 weeks is possible. Okay, so these are some changes. So what is the best method for MTP? It depends on when the MTP is being performed. If it is performed before 7 weeks, then medical termination of pregnancy is best. Likewise, medical method. Okay, no, not surgical, medical method before 7 weeks. From 7 to 15 weeks, suction and evacuation is preferred, and beyond 15 weeks, prostaglandins are preferred. Okay, so let's talk about medical. So in medical termination, what we do is on day 1, we give the patient mifepristone tablet, 200 milligram. Okay, and on day 3, we give the patient misoprost, 400 microgram. Okay, day 1 and day 3, misoprostol and misoprost, 200 milligram, 400 microgram. Okay, and the abortion or MTP is completed by 15 days. Okay, but sometimes if the patient is between 7 to 9 weeks, we can also advise her medical termination medically. In India, below 7 weeks medical is preferred, above 7 weeks it's not preferred. But if within 7 to 9 weeks we go for medical termination, then the dose of misoprost instead of 400 microgram is 800 microgram. Okay, if it is between 7 to 9 weeks. Okay, coming on to between 7 to 15 weeks, we use suction and evacuation. So we use MVA, manual vacuum aspirator, and first we dilate the cervix with the help of Hagar's dilator, and then we insert MVA. So this MVA generates a pressure of around 660 mm of Hg, and the volume of the syringe is around 60 ml. So we insert it, we create a vacuum and suck out all the products of conception. If it's after 15 weeks, so suction and evacuation can be difficult. So after 15 weeks, we prefer using prostaglandins. So we can either use PGE1 or PGF2 alpha. Okay. Yeah, so that's all about MTP and abortion. One more thing, this abortion and MTP are causes of early trimester hemorrhage. Okay, hemorrhage in early pregnancy. We will also see about ectopic pregnancy mostly tomorrow. Till then, enjoy and keep studying. Chalo, bye.